Someone got disconnected.
Okay, ma'am.
Yes. Can you see now? Okay. If you're ready, can I start the timer?
Okay, ma'am, I
Dr.
am
Moore?
ready.
Yes. I'm sending live. So I'm starting the timer, and here is the station. Right. If you have read and understood, kindly tell me, considering it critical care station, how would you manage this patient?
Okay, the manage the patient according to the ABC approach of the CRISP protocol. Airway assessment, speaking the patient if can speak secure airway, if cannot speak look for any foreign body and check on your breath and listen for any added sound, and the manage it with the shell lift angiotrasta, removal of any foreign body and secretion by the forceps and the suction, and then endotracheal intubation, and then breathing assessment by inspection for for the chest symmetrical and the counter respiratory rate, and then palpation for the trachea centralized or no, and then percussion and the auscultation to exclude any abnormality, and then circulation assessment. Two large bore cannula in the antecubital fossa, take full blood count, urea and electrolyte and blood group, and cross match. Start resuscitation the patient with 1 liter of bolus of the crystal light. If not respond, can be added 1 liter of the crystal light. Would monitor the patient with blood pressure and urine output and pulse and respiratory rate and the mental status. My professional diagnosis regarding the case scenario could be anterior-cutaneous fistula, and another differential diagnosis could be leak from the anastomosis, and there could be pseudopancreatic cyst, and there could be gastric stomach.
Very good. Okay, how would you accomplish your, or how would you make your diagnosis confirmed?
Yeah, confirm diagnosis by ultrasound and CT scan, and CT scan for the abdomen and pelvis, and the fistulogram to confirm and delineate the tract, the ligament, and locate the fistula and locate any distal obstruction.
Very good. How would you classify fistula? What are the all possible ways according to which you can classify fistula?
Yes, classified
Enterocutaneous
according to the
fistula, yes.
congenital and acquired.
Yes. Yes.
Classified according to the congenital and acquired, and etiology by infection and inflammation and malignancy and radiation, and
Yes.
internal and external fistula, and the simple and complex, and according to the anatomy, colovaginal and
Yes.
physicocolic and enterocutaneous, and the physiology, high and low output
Very good.
according to the secretion. If less than 500 low output, if more than 500 is high output.
Very good. Okay, can you tell me how would you manage, or how would you take care of nutritional status of the patient?
Yeah, the nutritional support according to the body weight detected by the dietitian. The start the patient with the total parenteral nutrition with monitor fluid and the electrolyte. The patient require the calorie from 25 to 30 for the normal person, and from the 45 to 55 for the extensive trauma.
All right, good. What are the complications that you can expect because of enterocutaneous fistula?
Yeah, the complication could be sepsis, could be electrolyte disturbance, could be fluid abnormality, and could be metabolic acidosis and the excretion of the skin, and it could be lead to sepsis, lead to severe sepsis and septic shock.
Very good. So what are the signs that you look for if there is a suspicion of intra-abdominal sepsis?
Yeah, by history, nausea and vomiting, and
Yes,
abdominal tenderness and rigidity, and the tachycardia and hypotension, and the swinging pyrexia.
very good. Okay, can you tell me what can bring a patient to the operation theater within 24 hours?
Yeah, if
Patient has,
the
yes.
patient with distal obstruction and intra-abdominal sepsis.
Can you discuss the surgical management of enterocutaneous fistula?
What's ma'am?
Surgical management of fistula.
Okay, the surgical management after trial of the conservative treatment for 1 month, patient after sepsis control and nutritional support and adequate fluid and electrolyte replacement and protect skin, and the surgery depend on the patient free with the sepsis. Start the surgery as excision of the fistula tract with resection of the bowel involved and the anastomosis, and another option externalization of the remaining bowel followed by delay anastomosis.
Very good. What are the risk factors which can predispose to enterocutaneous fistula? Can you name few?
Yes, like infection and Crohn's disease, cancer, radiation, ischemia, and intestinal anastomosis.
Very good. Okay, can you name few factors which prevent spontaneous healing of fistula or closure?
Yeah, as malignancy, infection, radiation, Crohn's disease, malnutrition, high output fistula, distal obstruction.
Good. If you'll take the ABGs of arterial blood gases of this patient, you will find that patient is acidotic. Can you explain why?
Yeah, because acidotic because of the loss of alkaline pancreatic juice lead to metabolic acidosis and loss of the electrolyte during the fistula tract with the fluid and the nutrient and lead to lactic acidosis, lead to low bicarbonate and lead to metabolic acidosis according to the Hasselbalch equation.
Very good. Can you tell me where this bicarbonate is mainly produced?
Yeah, mainly produced from the pancreas.
How would that affect production of enzymes from the pancreas? Would that affect it or not?
Yeah, affected on the pancreatic enzyme, especially trypsin, lead to excretion of the skin and advise the patient on the to prevent the excretion of the skin. Put the patient on the zinc because of the contain trypsin enzyme.
Very good. What are the blood tests that you'll continuously monitor for this patient?
Yeah, continuous monitoring the patient, full blood count, as WBC, and the fluid and the electrolyte like sodium and potassium and urea and the creatinine.
What measures would you take to protect the skin from excoriation?
Yeah, to prevent the excretion of the skin, put the patient on the like zinc ointment and zinc tablet.
Yes, and to make sure that there is no distal obstruction. If occurs, then relieve it immediately. Okay, what are the other components of principal management, conservative management?
What's mom?
What are the other principles of conservative management of enterocutaneous fistula?
Yeah,
There is one sepsis,
the
there is
SNAP
one
protocol,
skin care.
sepsis control,
Yes.
nutrition and support.
Then
Yeah,
anatomical access.
SNAP protocol like sepsis control,
Yes.
nutritional
Yes.
support, anatomical assessment, adequate fluid and electrolyte replacement, protect their skin, and plan for the surgery after empty knitting.
Very good. Yes. With this, our station ends. Good. Excellent. Thank you. Can
Thank you,
you
ma'am.
discuss this image that you're looking at? Bell has gone, but still.
Yeah, this is
What do you
fistula.
see?
Yeah, this is fistulogram. IMC tract extended from the anastomosis and into the abdominal wall cavity.
Yes. Very good. Thank you. Yes. Thanks. Yes. Good evening. More members have joined.
Thank you.
Thank you, Dr. Mohammed. Yes. Anyone asking question? Yes.
Dr. Samir, thank you, Dr. Lalai, for
I can hardly hear you. Can you bring the mic near to yourself?
Dr. Samreen, first of all, thank you to Dr. Alain for explaining all this scenario. I just want to learn uh, uh, where to read this topic from the textbook, or is there any handout in the
Yes,
group?
there are
I
traditional
think I
notes.
lack this in this
Yeah,
topic.
I think I shared before as well. I'll send you again. There are traditional notes. The books are the ones. Yeah, there are no such a book. If you'll go into the books, then there are so many books, and like going into the books, like it will be like wastage of time. Just focus yourself on the
Hmm.
traditional notes, and then that will be time saving and
So,
more.
are you talking about Turkey notes? Are you talking about
No,
Turkey
no, I'm not
notes?
talking about. No, no. He's selling his package. You can take his package from him. I'm talking about the other those traditional notes which are available free of cost in the market. They're
Hmm.
good enough. They can still make you pass. Many members have passed by using them.
Kindly share those notes on the group
Yes, I'll
if
send you
possible.
again. Yes, I'll send you copy of my blog. I have that blog on WordPress. I'll send you and you can read from there. Them.
Thank you.
Everything is given over there, but still, like if you want to read more, then you can read that from the critical care book that I've recommended. I'll show you again. Yeah, I'll send you again.
The
It's given in the
Kanani, are you
blog.
talking about Kanani, or
Yeah,
the
yeah, yeah,
Cambridge
yeah.
published?
Yes, that gives. Yes, yes, that one, Kanani or etc. Yeah, that one gives you extra vision to handle the critical care scenarios. That gives you extra tools. So that's good. With that, you can cover all the critical care scenarios. So that is good. But like other MRCS books, like they'll take too much time. Who got disconnected? Someone got disconnected. Yes, Dr. Mohammed Al Tahir is here. Should we take your station now? And then we can take Dr. Mohammed Ilyans again. People are getting disconnected. Yes, 20 minutes. Okay. All right. Then we have Dr. Sunday and yes, and Dr. Aisha is here as well. Maybe she would also want to. Yes, Dr. Sunday, which station should we arrange it for you? Good evening, Dr. Sunday. Are you there? Can anyone hear me?
Yes, ma'am, we can hear you.
Would
Yes, ma'am,
you?
I'm here.
Yes. So, uh, I think Dr. Sunday is also busy. Dr. Aisha, would you want to go for any station? Can you help Dr. Muhammad Ilian with communication skill? Can you, Dr. Fatumata, help?
Yes, I can help.
Okay, good. Dr. Mohammed Elian, ready?
Okay, ma'am, I am ready.
Yeah, Dr. Fatumata will help you, okay?
Okay, no problem.
Yes. Thank you, Dr. Fatumata, for helping.
Okay, you're welcome.
Yes. All right. Because I think Dr. Sunday is busy. Otherwise, he always answers, replies. And Dr. Aisha is maybe also. All right. I'm starting timer. Here is your
Okay,
question.
ma'am, I am ready.
Yes. Yes. So if you have read and understood, kindly begin your station.
Okay, ma'am. Hello, I am Mohammed one of the surgical doctor registrar working for me. I'm calling to speak Mr. David as HEPATO-BILARY consult to ask him advice about the patient for this post-cholecystectomy. Patient complain of the abdominal pain, nausea, and tachycardia. Can I check that I am speaking to Mr. David?
Yes, please, you're speaking to Mr. David. Yes, please, you're
Okay,
speaking
nice
to Mr.
to
David.
speak Mr. David.
Mm-hmm.
Can you summarize
So,
your case
Okay,
now?
can you please summarize
44
your
years old.
case? Mm-hmm.
44 years old female post-cholecystectomy for this complaint of abdominal pain, nausea, and tachycardia. By investigation, total leukocyte increase and the CRP50 and the bilirubin high, and done ultrasound showing free fluid in the abdomen and no CBD dilatation. After assessment, the patient, according to the CRISP protocol, I think the patient by lake post cholecystectomy. I am calling to ask advice about the patient and refer to send the patient to a hepatobiliary center.
Okay. So, what do you think is wrong with the patient?
I think the patient bile leak post cholecystectomy.
Okay. So, what investigations have you done for the patient? And then, is the patient stable or unstable?
Yeah, the investigation done full blood count like increase total leukocyte and the CRP15 and the bilirubin is high.
Okay. So, what else should I ask? Okay.
Why
So,
is
what's
CRP
your
high? Is there any infection?
yes? Why is CRP high? Hello.
Hello.
Yes,
Hello. Why is the
Dr. Muhammad.
CRP high? Why do you have a high CRP level of 50? Is there any
Yeah,
infection?
because the CRP
Because you
is
said
acute
it's
phase
post
protein.
day 4.
Yes, the CRP is acute phase protein likely due to reason due to the operation, or maybe due to bile leak lead to the bile leak lead to biliary peritonitis lead to increase CRP and the WBC.
Okay. So, are there any signs of peritonism in this patient? Have you checked?
Yeah, the patient generalized abdominal pain and by examination to the vital sign tachycardia and another
Okay. What's the urine output of this patient? Is the patient in shock or not? Have you checked?
No.
Have you checked that?
Dr. Muhammad.
Hello?
Network, I think. Yes. Is the
So what's
patient
the
in
urine
shock?
output of this? Is the patient in shock?
Yeah, the patient need resuscitation and stabilize the patient. Start with the crystalloid and monitor the patient with blood pressure and urine output and the respiratory rate and the capillary fill time and the mental status. If not respond to the fluid resuscitation, can be added blood transfusion and can be added inotrope.
Okay. So are you planning to, why can't you do the surgery in the hospital? Because the patient has peritonitis before transferring. And the patient is in
Yeah,
shock.
because of the biliary peritonitis can lead to septic shock. Patient need surgery.
Yes, so patient needs surgery and it's urgent. So, but why do you want to transfer urgently to us? Who was the surgeon?
Yeah, to avoid the chemical peritonitis. After stabilize the patient and resuscitation, the patient need the surgery.
Yes. Why
Okay.
she's asking that why is it urgent? Do you need to talk to someone?
Yes, this is urgent.
Bed manager or something? Yes. Yes. Do you need to talk to someone? Bed manager or someone?
Yes, yes. For fear of
Bed
develop
manager?
biliary peritonitis, I need the need bed manager of the hospital to discuss creating bed whether by facilitate discharge or repartition of the patient.
Oh, okay. So how about if we don't have bed space? What happens? What would you do?
Yes. If there's no bed space available, what would you do meanwhile you're waiting for the bed?
Yeah, I will alert the bed manager in the both hospital of the urgency of the transfer and ask if they have any way of the creating bed for this patient, for instance, by facilitated discharge or repatriation of the patient.
Okay.
Okay. What management do you think should be done?
Done for the patient.
Yeah, the manage the patient after stabilize the patient, IV drip and put the patient on the antibiotic and arrange for the MRCP for diagnosis and the ERCP to diagnose the site of the injury and as a diagnostic and the therapeutic to put the stent and the community refer to tertiary hepatobiliary center for appropriate definitive management by stent placement and restore biliary continuity by RONY choledochodynostomy or hepaticojejunostomy according to the Strasbourg classification of the bile duct injury.
Okay.
Does the patient have drain in it, in situ?
Yes, it's important.
If the drain in situ watch and monitoring till the peritonitis, ERCP and stent and laparoscopic lavage.
Is that does the patient have the drain in situ? I think you're supposed to answer that question.
Yeah, if the drain in the situ wait and watch till peritonitis, done ERCP and stent and the laparoscopic lavage and the drain insertion would repair the leak and repeat the ERCP after 6 weeks with the stent removal. If no drain, done ultrasound and the drain insertion. If no peritonitis, monitor the drain. If the more than 200 milli every day, ERCP and stent. If the less than 200 milli every day, resolved with the conservative treatment.
Okay. That's fine.
So what does ERCP stand for? Yeah. And what does it involve?
Yeah, the ERCP standard for endoscopic retrograde cholangiopancreatography. This is X-ray to examine the common bile duct and the pancreatic duct by operator pass flexible telescope down to the esophagus and to the duodenum. Inject the contrast through the ampulla of fata to allow the bile duct and the pancreatic duct and the hepatic duct and visualize it under X-ray token. the bile leak result by extravasation of the into the abdomen. This is diagnostic and therapeutic to detect the site of leakage and if any residual stone removed by extraction and sphincterotomy and to remove any pressure of the bile on the duodenum, and after that put T-tube for the 6 weeks and removal with the repeated Ercp.
Good.
Good. Could you arrange
That's
Ercp to confirm the source in your hospital?
Yeah, this is not available in their hospital.
Okay, then send patient over.
Okay.
Thank you.
I
Bell has
have 3
gone,
questions.
but you should say thank you. Yes. Yes, please.
So, where you asked him about if there was a drain in situ, so he just went on explaining if there's a drain, if there's not a drain. But I thought he should have answered that he didn't check. He would have gone back to check, and then he could go on, because it was just like because it's a scenarios, and then you asked him something. So I thought he was supposed to answer that before he could go.
There was no drain in situ. Yes.
Yeah,
Is
no
that
drain
what you're
inside.
saying?
Yeah.
Yeah.
Yeah. Regarding the case scenario, no drain inside too.
Yeah.
Okay.
Dr. Fatimata, he did. Yeah, he did great. Yes. And
Yes,
thank
yes,
you,
he
Dr.
did. He
Fatimata,
did
as
well.
well. Any more question anyone have?
Thank you, ma'am.
Yes. Anyone else?
Fatimata.
Yes. Dr. Fatimata, thank you so much. Yes. Anyone else have any more questions to Dr. Muhammad Ilyan? No. Thank you so much. Thank you, Dr. Fatimata and Dr. Muhammad. Now,
Thank you, ma'am.
thank you so much. Dr. Muhammad
Thank you
Al-Tahir.
so much.
Thank you. Dr. Muhammad Al-Tahir, are you ready now? Or you 20 minutes haven't
Yes,
time
I'm
left?
ready.
All
Good
right.
evening.
Good evening. Yes. Okay, good. Just a second. Let me get things ready. Okay. Give me a sec. Right. Who's saying what? Yes. Good. Thanks. Station. All right. So if you're ready, can I start the timer?
Okay.
Okay. Here is your question and timer have started. Right. If you have read and understood, let's begin our station. Can you please identify the structures from in the left picture from A to D? Where is this pointing at?
Okay, A, this is the tibial
Very
prominence.
good. And B?
A, this is the fascia for tibialis anterior.
Very good. And C, please?
C, this is the superior extensor retinaculum.
Very good. And D?
is the peroneal longus and the
brevis
peroneal
tendon.
brevis.
Very good. Can you
Tendon.
tell me how these structures from medial to lateral or superficial to deep are passed below the retinaculum, extensor retinaculum? Can you name the structures? There is one common
From medial to
idiom or
lateral?
yeah, yes please. Can you name the structures which pass through?
There's extensor hallucis longus and the extensor
Yes,
digitorum longus
yes,
and
and
the peroneal brevis and peroneal longus.
okay, there's all right. If the, we'll do that again. Okay, can you tell me how would you
Okay.
differentiate if there is compartment syndrome of the anterior? How many compartments of the leg are there?
There are three compartments, the anterior
Yes,
compartment and the posterior compartment and the lateral
yes.
compartment. The
Can you
anterior
name the
compartment is
muscles present?
separated
Yes,
from the posterior.
yes,
It's separated from the posterior by interosseous membrane. The anterior is separated from the lateral by anterior fascial septum. And the lateral
yes,
is separated from the posterior by the posterior fascial septum.
yes.
There is a muscle in the anterior,
And then the posterior is
extensor digitorum
separated.
longus,
Yes,
and the
yes.
extensor has
There are actually four
and the
compartments. In the
extensor
posterior,
hallucis
there are
longus and the tibialis anterior muscle.
posteriorly there are two
Superficial and deep,
compartments.
yes.
So yes. How are they? How are they divided?
There is anterior is divided from the posterior by interosseous membrane, and the
Yes,
anterior
I
is
asked.
separated from the lateral by the
Yes.
anterior fascial septum,
Yes. Can you please tell me
and the
the
lateral is
name?
separated from the posterior by
Yes.
the posterior fascial. Okay.
I asked for the deep, superficial and deep posterior
Okay.
compartment only. Okay. Can you please tell me the name of the nerve and the blood supply of each compartment, please?
Okay, the anterior compartment, it's the nerve supply by the deep peroneal nerve, and the blood
Yes.
supply by the anterior tibial artery.
Very good. And
The
then
lateral
lateral.
compartment, the nerve supply the superficial peroneal nerve and
Yes.
the peroneal artery.
All right.
The posterior compartment is supplied by the tibial nerve and the
Yes.
posterior tibial artery.
And the deep compartment, posterior deep compartment, that is of the same. Okay.
By the tibial nerve.
Yes, a tibial
Yes.
nerve and the posterior tibial artery is the same. All right. Can you please tell
Yes,
me how would
same.
you differentiate if there is compartment syndrome of the anterior compartment of the leg?
Okay, if the anterior compartment syndrome, there will be swelling and pale and pulseless and paresthesia, and there will be pain out of proportion on the plantar flexion of the leg. This is the
And
posterior compartment. There is pain out of proportion on the flexion of the leg.
yes, upon what? How would you confirm your diagnosis? Active dorsiflexion. Upon
Active,
active.
yes.
All right.
Ma'am,
Okay.
active or passive?
Active. Active.
Active.
Because you're confirming it. Okay. Can you please identify the structures on the right hand side picture from A to D, please?
Okay. This is the
Yes.
popliteal artery,
What?
popliteal angiogram.
Yes. Okay. Very good. Yes. Now tell me. Angiogram.
A,
Yes.
this is the popliteal artery.
Yes.
And the B, this is the anterior tibial
Yes.
artery. And C, this is
Anterior
the
artery.
posterior
Yes.
tibial artery. And this is D for the peroneal artery.
Okay. Can you tell me what are the clinical features of compartment syndrome?
Okay, there's be leg swelling and pain out of proportion, and there'll
And
be leg tenderness and pale and paresthesia and pulselessness.
Okay. Can you tell me what is the terminal branch of C, artery C, that you have just told me? How does this artery ends? What is the terminal
Posterior
branch?
artery, plantar and lateral plantar artery.
So what would be the origin of dorsalis pedis artery?
It is the continuation of the anterior tibial artery.
Yes. Okay. Can you tell me what does the sural nerve supply? From where does it origin?
Okay, it is supply the back. It is been deep quadrant nerve of the common peroneal nerve and supply the back of the leg and the lateral part of the foot and the fifth toe.
Okay. Can you tell me this, looking at this vessel C, can you please tell me between which structures it runs at the medial malleolus? So imagine the structures passing at the medial malleolus. This vessel runs between which muscles or which structures? What is the relation of this vessel at medial
Okay, the
malleolus?
posterior tibial artery.
Yes?
Uh,
Can you name the structures which pass at the medial malleolus? Anterior to posterior? There is a mnemonic,
there is a
famous.
posterior tib. There is a posterior.
Tibialis
The
posterior, then yes,
tibialis, tibialis posterior and posterior tibial artery, posterior tibial nerve,
yes,
and the
and
flexor hallucis longus.
yes, hallucis longus. So, all right, posterior. Okay, right. Can you tell me the nerve supply of the? And you told me anterior compartment. Okay, can you tell me the muscles of anterior compartment? Last question, please. What are the
The
muscles
extensor
of anterior
longus
compartment?
and the extensor hallucis longus and the tibialis anterior muscle and the peroneus tertius.
Okay, peroneus tertius, anterior tibialis, extensor distal longus, extensor hallucis longus, extensor distal brevis. Very good. Okay, thanks.
Thank you.
Thank you. 6 P's, yes. Right. Someone got disconnected. Okay, well done. Dr. Mohammed Altair, you are here or you got disconnected? No, you went down. Okay.
I'm here.
What happened? Yes, that mnemonic I was asking. It's the famous one. And Dr. Mohammed Altair, one thing, you have to remember all the structures passing through the external retinoculum.
Okay.
This is the mnemonic. It's very famous one. People use it. I know it's inappropriate, but this is what people remember it from. Yes. So, yeah. Anything else I could have asked you on, because you are just doing it. Okay. Those six P's, Dr. Mohammed, can you tell me? On fingertips, these are the clinical features that you should remember. 6. Okay.
The pain and pale and toughness and paresthesia.
Yes, and
perishing pale, puffness and
perishing cold
paresthesia and perishing cold.
and paralyzed.
And
And paralyzed.
yes,
6-1.
pale, puffness. and paralysis. Yes.
Paralyzed 6. Okay, good. Very good. Okay, now you know you are done. Right. Good. Anyone else wish to go for any station?
Dr. Samreen, I would like to volunteer.
For which one, Dr. Burhan?
Any station you would like to nominate me for?
For tomorrow?
Or for now,
For
if
today?
there's gonna be a
Yes, there is. I'm sitting and waiting, but if there is any that you would want to choose in particular, because I know you're a beginner, I don't know how much to press you or how to evaluate you, so I give you freedom to choose.
then I would like to
You
choose
want to
from
go ahead
anatomy.
with not? Okay,
Anatomy.
all right. Any particular area, limbs or head and neck or anything?
Limbs.
Okay. So let me get the questions out. Lower limb or just a second,
Upper limb.
upper limb. Just a second. Okay, I've chosen one easy one and I'm sharing it now. It's easy. I'll give you 1 minute to read the question. That's how professional exam goes on. You'll be standing outside the bay and you'll be given 1 minute to read the question. Bell will go, you'll go inside, you'll meet the examiner, you'll be given 8 minutes, 9 in current scenarios to answer the questions, to identify, because it's an anatomical station, so you will be asked to identify the structures and answer the related questions. Right. And in
Right,
that
ma'am.
given time, sometimes you can finish earlier, depends upon how active you are and the questions I ask very slow because it's the end of the day at my end and I'm lazy. I ask very slow, but they ask very quickly one after another and then they don't give you that much time. So actually I'm
Certainly.
looking for, well, I'm looking for my question. Okay, so I'm giving you timer. If you're ready, I'm starting the timer. 1 minute, like I said. Timer starts now, and here is your question.
Yeah, all right, ma'am. I have read the question.
Yes, just wait, please. Bell will go soon. Right. So if you have read and understood, let's begin. Can you please identify this orange area?
This is anatomical snuff box.
Okay. Can you tell me what are the most likely structures which can get injured if a patient complains of pain on palpation at this region?
First of all, given the mode of injury, scaphoid bone can be fractured in this area.
Very good. What are the other structures which are contained within the anatomical space?
Radial artery.
Very good. So can you please tell me the boundaries of this area? Or in other words, I'm asking you to identify structure A, B, and C, please.
The A represents the tendon of extensor pollicis longus, and B represents two tendons of abductor pollicis longus and extensor pollicis brevis, with extensor
The other
pollicis
one is
brevis
C.
being on.
Yes.
Okay,
Yes.
the B is extensor pollicis brevis, and C is abductor pollicis longus.
Yes. Okay. Can you please tell me which peripheral nerve is responsible for the sensation within the green shaded area on the back of the hand? So now I'm asking you to move on to this green shaded area. So what is the nerve supply?
This green area represents the innervation of radial nerve.
Can you please describe the course of radial nerve in the hand?
Radial nerve, after it
It enters the hand above the extensor retinaculum or below. How does it enter the hand?
yeah, it enters below the extensor retinaculum.
Okay, then what happens? You have to read that. Read
Then
this
it
question.
gives it gives a deep branch and a superficial branch.
You can't just say deep and superficial. You have to tell me motor or sensory and in detail. This is your homework question. Okay, can you please tell me what are the muscles that are innervated by the radial nerve in hand?
In hand, radial nerve supplies the extensor muscles,
All right.
specifically.
You'll read this. Very good. Okay, can you please tell me what happens when there's a damage to the radial nerve at three locations? I'm going to ask you within the axilla, at the level of the mid-humerus, and at the wrist, please.
Within the axilla and the
Yes, please.
humerus, and the third one, wrist.
Yes, please. At the wrist, yes, please.
If it is severed in axilla and humerus and at the wrist, all three will result in wrist drop. And specifically, if the damage is in axilla, the tricep muscle action is lost, and the arm hangs by the side in a
Not
posture
quite.
called Saturday night
Yes,
policy.
not in.
Saturday night
Yeah, but not in
policy.
all of them. We'll discuss it. Okay, in which dermatome is the region of the skin labeled D? Now I'm coming on to the extreme, this area, D. Please tell me, in which dermatome is the region of skin labeled D? Which nerve
See,
innervates the skin over region D?
yeah, this region is represented by dermatome C6, and the nerve is radial nerve, superficial branch, radial
Okay,
nerve.
well, can you please identify on this picture? This is right hand, you can see right. There are four images. Moving on to the left one. Can you identify A and B, please?
Yeah, this A is scaphoid, B is distal radius.
Can you identify this C in the picture below, left below?
This is
C?
this is head of the first metacarpal.
Not necessarily head, chef. Okay, can you identify D in picture right upper corner? D.
I think this is scaphoid.
Can you identify E, please?
That is distal part of the ulna.
Okay, can you please describe the blood supply of the scaphoid bone, please?
The blood supply of the scaphoid bone is from the radial artery, and it originates from the distal part of the bone, running towards the proximal part.
Okay, can you please tell me what may be the clinical consequences of missing a scaphoid fracture on the radiograph?
The consequence of this fracture in a long term is avascular necrosis.
Yes, missing.
And hence
yes.
the non-union.
Okay. Which part of the scaphoid bone is most prone to this complication that you are mentioning?
The distal part.
Good. Can you name 3 other bones within the upper limb or the lower limb, which may also be at risk of this complication? There are 5 bones altogether, right?
Yeah. So the other bones, one is head of the femur, avascular necrosis, head of the femur.
Very good. And 4 others. One is scaphoid, then at least 3 more. 5 more, 4 together, 4 more. All right, you'll read this. Okay, can you tell me, in the absence of trauma, in this scenario there was trauma, in the absence of trauma, what medical conditions or risk factors can also give the same history and when complicating the same disease? The same complication that you are mentioning that resulted as a result of trauma. So what medical conditions can result in the same complication without trauma?
Peripheral artery disease.
Like? Give some examples, please. Any autoimmune disease, you have to give me examples.
Ma'am.
That's all right. We're thinking. Bell is gone. So now time is all ours. We'll think and we'll decide and we'll answer.
Yes.
Because what you did is the best way of learning. You come without telling me, I give you surprise station. It's not about doing excellent today, like in front of me. It's like what you learn. So if you cannot answer any question today, you'll go back and you learn the answer and you'll remember this for the rest of your life. This is the best way of learning. I really appreciate the way you did, Dr. Burhan. So whatever you'll answer, I'm happy because your way of learning is the best way. All right, I'll tell you.
Yes, ma'am.
So the conditions, see, they're very common. Any condition in which patient has been taking long-term corticosteroids, right? Any condition where patient has been subjected to radiotherapy, any autoimmune conditions like rheumatoid arthritis or systemic lupus erythematosus, any sickle cell disease, like this is like it happens in sickle cell disease as well. So these are the 4-5 you can commonly, but like in exam condition, because of stress, you can't remember the names of diseases. So it's better to say any condition in which patient has been taking long-term steroids, radiotherapy, sickle cell disease, autoimmune disorders, like then you can like get away with the question very nicely. Okay, and then those
Right.
common avascular necrosis sites. One you told me scaphoid, another you told me femoral head of femur. The disease called, what is the name of the disease? Perthes disease in children. Does this
Yes.
disease have any
Perthes
name
disease.
in adults? If there is femoral head avascular necrosis occurs in an adult, what would be the name of the condition in adult?
Stupid upper femoral
Chandler.
hypophysis.
Yeah, it's called Chandler's disease. What should
Chandler's
be the
disease.
treatment? Yes, Chandler's. What should be the treatment?
The treatment would be replacement of the joint.
Yes. Or
Osteotomy.
resolve the condition. Or resolve the
Total hip.
condition.
Total hip
Yes,
replacement.
total hip. Okay. Another condition, another disease, another bone is lunate. Avascular necrosis of lunate has a special name. It's rare, but it happens. Can anyone tell me? Kienbock's
Swedick
disease?
atrophy. Swedick
No,
atrophy.
no. It's affected. It mostly affects the dominant hand of the patient, and only in 2/3 of the cases. It's rare, but it's called Kienbock's disease. I'll send you all this table. All right. Then
Ma'am,
another
what's
example
the
is
name?
thallus.
What's the name? What's the name?
I'll
Please
write it
repeat the
here.
name.
I'll write in the chat.
Kienbock disease.
Yes, I'm writing. There is on the O there are 2 dots, so I think it's from my part of the world. Kienbock's disease, it's called. It's rare, and that's for lunate. And can you tell me if it involves thallus? What is the name of the disease? And that can lead to total loss of ankle joint with destruction and deformity in severe cases. You may not need to know all this, just the name of few because when the question is asked, just on the tip of the fingers, you can remember the name of the bone. Once you'll tell them the name of the bone, no one would go into details, but it's just for the sake of knowledge. Dies disease, it's called DIAZ, dies. Okay, for navicular, does anyone know what does it call?
Kohler disease.
Very good, yes. And then there is another one, last one, head of the second and third metatarsal bones. What is the name of the bone? What is the name of the disease? Pre-Barry's infection. It's mostly seen in female runners. Pain is felt in the forefoot and it may resolve spontaneously when they stop running.
Okay, the Kohler disease is of the avian of the navicular bone. Kienbock disease is for lunate.
Yes, and this is Pre-Barry.
And what about Friedberg's
Doyle's.
disease?
This was for the second head of the second and third metatarsals. Second
head
and
of
third,
second and
head of the second and third. Yes. And this is dies for the thallus. It can lead to total loss of ankle joint with destruction and deformity in severe cases. And navicular, you already maybe know.
Thank you, ma'am. Thank you so much. That was all new information for me.
That's good, but then you have to remember the radial nerve, the course of radial nerve. It's very important. That is take-home message for you. Okay, can you tell me once again all the from A to E, please? A was scaphoid bone, B was
Distal radius.
Radius. Okay, C please.
Head of first
Or the
metacarpal.
first metacarpal. Okay. And this D.
Scaphoid.
It was lunate.
Lunate.
Yes, they said it looks very lunar. So you have to look closely. Does it look lunar? Lunate means lunar, moonlight, incomplete. And then
Okay.
this one is ulnar. E.
Distal ulna, yes.
Yes. Okay. D. What did you say D was?
D was the dermatome represented by C6.
C8. Okay. Here is C6.
Okay.
This is C7 and this is C8.
Okay.
Yes. And the dorsal cutaneous branch of ulnar nerve supplies this area. That's why it's important. A radial nerve does not supply here. It's C8, so it's dorsal cutaneous branch of ulnar nerve which supplies this area. Okay?
Yes.
Right. Right. When you're telling me the boundaries of the anatomical snuff box, then kindly tell me, you told me what is on median lateral, what is the content, then what is the floor and what is the roof?
The floor is formed by scaphoid bone.
And trapezium.
Lunate.
Part of,
And
no, trapezium.
and radial artery.
Proximal, and the proximal border of stellate process of radius as well. Content is radial artery.
And the proximal border of
Stellate process of the radius.
stellate process. Okay.
Okay, and then it's just radial artery, and in the roof there will be stellic vein and the radial nerve that overlies this space. So radial nerve, stellic vein, and the radial artery. These are all the contents of the anatomical snuff
Cephalic
box.
vein.
Okay,
Okay.
good.
Okay.
Right, we are done with the anatomical snuff box, and we are done with the leg as well. Very good.
Thank
Head
you
of ulna.
so much.
Yes, thank you so much. Right, very good, Dr. Burhan. Very good, excellent. Your way of learning is excellent. This way you learn better. That's what my previous initial members did, and they did superb with this learning. You know, you'll go back,
Thank you.
you'll revise what you missed today, and that you'll remember for the rest of your life before exam. And then you can also go back. I'm sending live, and then it will be available immediately. You can go back and listen and learn the questions you couldn't answer now, and it will be magic before exam. Very good. Anyone else interested, or we can call it the end?
Thank you so much, ma'am. Thank you.
Thank you so much. Very good, excellent, really impressive. All right. No one is interested. No one is saying anything. Then we'll meet tomorrow, hopefully. Yes.
Thank